So we're going to go to a slightly different session now, which is basically a continuation from one we had yesterday in the morning. This is at a time that is more suitable to some of our colleagues who are joining in this case, from the Americas. And we're going to hear these overviews of country experiences where the speakers will speak one after the other, taking us through, first of all, an overview of the impacts of the pandemic, the lessons that have been learned or should be learned, and some of the initial discussions about reforms that should follow from the pandemic. And I'm very pleased, I don't see Mariana from, Mariana is here also, so yes, so and it's great to see that all the speakers are here. We're going to hear first from Canada, then we'll go to Israel, Mexico, Norway, and we'll end in Germany. And if we're going to have all the slides in a deck, then we'll have the German ones. And Daisy, if you're ready to start sharing, and Janice, if you're ready to go first, I think.
Hey, thanks very much, Alina. It's great to be here again. Next slide, please. So I'm going to tell you a bit about the lessons learned from COVID-19 in long-term care in Canada. Next slide, please. And those are, I'm at the University of Mount St. Vincent University in Halifax, Nova Scotia, and director of the Nova Scotia Centre on Aging. Next slide, please. So this is a map of Canada for those of you that aren't familiar with us. This is, so what I've done here is, there's a lot of numbers because of course Canada is a federation, but the health and long-term care is a provincial jurisdiction. So we have 10 provinces and 13 territories. So the reporting is done by province. And so the red reports are the provinces where of all the deaths of COVID up until November the 29th, 2021, how many of all the COVID deaths, what was the proportion of long-term care deaths? So the red provinces, which is Nova Scotia, where I'm located, Quebec, Ontario, and Alberta, the residents represent more than 40% of all COVID deaths. The pink are those between 11 and 40% of all COVID deaths, and that would be British Columbia and New Brunswick. And then the blue, actually, there were no deaths due to COVID. So, so that's the deaths. So what was the proportion then of the next information I'm going to give you is the proportion of nursing homes that were affected by COVID-19. And so next click, please. Forgot. And one more click. Thank you. And so you can see that in the high of Alberta, there was 77% of the long-term care homes affected by COVID-19. Ontario, 67, Quebec, 51. Now, Nova Scotia only had 13% of their homes, and that was because there was one home that accounted for over 90% of the deaths. It was very early on. It was not, it was an older traditional type home with shared rooms. And so that was an initial learning from the first wave. So next slide, please. So what of our key lessons? We certainly have recognized in Canada that long-term care has had long-standing and pervasive deficiencies. There's a report by Wong Estabrooks et al., which talks about there being in the last decade over 80 reports indicating need for reform in long-term care. Those reports cost over $25 million Canadian, but nothing was done. And so this is the cumulative effect of years of underfunding, the increased comorbidities and complex health issues for residents coming into long-term care, and of course the human resource issues. Next click, please. And so what we found was a real difference across the waves, and that has the impact of vaccines. So the first wave, we were dismal. About 80% of the deaths in long-term care, or sorry, 80% of all COVID deaths were long-term care residents in the first wave. And that was because of lack of preparation, lack of attention, lack of physical capacity to be able to provide that infection control. With the first and second wave, it was still up at 70%. So as of November 29th, we were at 53% of COVID deaths, COVID-related deaths were long-term care residents. So we're improving. Oh, next click, please. Oh, this isn't coming in. Oops. Okay, there it is. And so that's just iterates the importance of vaccines over time. Residents were a high priority for vaccines, and they were the first on the line to get the vaccines, and most of them have now received the booster. Many provinces have introduced a vaccine mandate for staff. Sometimes there can be a workaround if they provide a test before coming into the workplace. Quebec and Ontario just recently backed down from that vaccine mandate because of concern over staffing shortages. But I can tell you in my province, they just released the data. There were less than 200 workers, I think, out of a workforce of 6,000 that didn't have a vaccine in long-term care. So they are 99% vaccinated as of this date. Next slide, please. So what are the key ways we're planning to reform? There was a report in July from the Royal Society of Canada talking about restoring trust. That called for some focus on standards, and there has since been both national standards for long-term care that are looking at promoting resident-centered care, balancing the safety with quality of life. There's 3 working groups: resident-centered care, safe, reliable, and coordinated care, and a healthy and competent workplace. Happy to send you, I'll put some of the links in the chat later on, but I think I want to stop here so I'm on time.
Thank you very much, Janice. Let me just jump in and say that just to test that our speakers are all very alert, we will change the order. And we're now going to go to Norway. Sorry, it was a bit of a mishap with the order of the slide desk. And it's not Germany, it's going to be Norway. So Frode, I hope you're ready. So, and next slide, Daisy, because that's our country. That's great, thank you.
So that's fine with me, and thank you very much for your invitation, Adelina, to tell a little bit about the Norway experiences. So the next slide, please. Yeah. So for Norway, our center got a job from a government of working for our National Corona Commission, mapping experiences of different actors in nursing homes of the COVID-19. So we did some observations to the extent that that was possible at all, and during COVID, and also we also interviewed physicians related to the facilities. We interviewed the leaders. We interviewed the care staff, and also we interviewed family. In addition, we worked together with our National Institute of Public Health to establish some statistics related to what was happening in the nursing homes. So in my case, it will be more on nursing homes than anything else, but also trying to cover a little bit more. So at the beginning of the COVID infection, which took us all by surprise. I mean, there were many Norwegians returning from holidays in the Alps and northern Italy at that time, and that was an unhappy coincidence. So So we found ourselves lacking in protective gear, and unfortunately, only 20% of the protective equipment was dedicated to the municipalities by the Norwegian state. The rest went to hospitals. That changed after a while, fortunately. Nearly 50% of COVID-related death took place in nursing homes. In our case, approximately the same as Sweden. So from mid-March 2020 till end of February 2021, 291 COVID-19 related deaths were in nursing homes, of a total of 638 in the Norwegian population. And we have a small population. It's slightly more than 5 million people. So 1% of the nursing home residents died during this first year of the pandemic, with 3% of the population infected. Most experienced the visitor restrictions, also physical and mental decline in residents during this period. So it really a severe toll on the residents, and also definitely on staff. So besides people going into quarantine, of the staff, also there was a high incidence of sick leave. Huge variation really between the nursing homes. So that stands out as a finding based on the statistics, where 4 out of 10 deaths occurred in the 10 nursing homes most affected, out of a total of over 700 nursing homes in the case of Norway. So the likely reasons for this, based on interviews with leaders, physicians, and care staff, is, of course, naturally it's hard to stop the disease after introduced, and also use of part-time and temporary staff, and thirdly, older buildings with less opportunities for isolation and for infection control. In the supportive housing, we don't have the same investigation and the same stats, but I could mention that 31.5% of the municipality introduced visitor restrictions, despite that only 28% approximately of those municipalities experience infected citizens. So that has been, in our case, quite much publicly criticized. Regarding home-based services, there has been reduced practical assistance in most municipalities, also with reported decline in physical and mental status of people receiving services at home. Next slide, please. So some lessons learned, and pretty much of this is based on our project for the government. Preventive and protective measures in infection control in municipal health and care services should be prioritized. Preparing long-term care for future pandemics means first and foremost improving conditions for care in general, and as in care as in normal situation. So that also echoes what we heard from Canada. It's a very important insight, and there needs to be a strengthening of the nursing homes regarding staffing, terms of employment, and in particular for nursing homes, the built environment. The fact that some staff work at more than one care home, and sometimes also in other sectors like restaurants, reveals the need for better paid staff with secure employment terms. There needs to be increased efforts at strengthening cooperation and integration between care staff and cleaning staff in nursing homes and supportive housing. And also further development of IT solutions based on needs to be performed based on experiences during the pandemic for enhancing also resident family communication. So since our country is relatively well off, we had introduced quite much IT solutions into the nursing homes, costly solutions, but without necessarily causing an education of people to use them. Also, there is a need in our case for nationwide mapping with regard to long-term COVID-19 experiences. Next slide, please. Yeah, so the next slide is quickly done because, well, at least in my opinion, we still lack reforms. There are many policy measures in place, but I wouldn't yet call them proper reforms. I have to mention in the case of Canada, we are very inspired at my center by British Columbia, where they really put so many measures in place early in the pandemic, also improving the general working conditions for staff in the nursing homes. Well, in December 2020, next of kin of victims of COVID-19 in nursing homes got the right of a financial compensation from the Norwegian government. And another reform, a new health reform in place 1st September 2021 with a right to use a choice of supplier institution-based the supply of institution-based and home-based care. I just mentioned it because this has been discussed because of the COVID pandemic. The present red-green government that just got elected and just began their works to reverse this reform, arguing that COVID-19 infection has claimed more lives in for-profit nursing homes, looking to Canada, United States, Great Britain, due to more workers working at more than one institution in the for-profit nursing home sector. The bigger picture, to conclude, a general lack of reforms so far is, I would say, is the situation in Norway related to the long-term care sector resulting from the COVID-19 experiences. There are many plans of new reforms, and I'm hopeful, but that's the present situation. Thank you.
Thank you very much. And now let's see which country comes next. I think we're going to now go to Israel. So Sharona, if you're ready, that's great. Yes. Thank you.
Can you hear me?
Yes, thank you.
Oh, okay, excellent. Thank you very much. Well, first of all, Adelina, I'm sorry, I have to take 10 seconds just to say that this day and a half have been absolutely amazing. The amount of information, data, resources, I have no words. It's really unbelievable, and I hope that you understand and feel how much all of the work yourself and all the colleagues and everybody who contributed to this project, it's absolutely amazing. So really amazing. Okay, so first of all, I'd like to present our small team of reporting for Israel, which is myself from Ben-Gurion University. Liat is from Bar-Ilan University, and we have Shuli Bar-Meli-Greenberg from the Hebrew University in Jerusalem. Next slide, please. Okay, so this is a short recap of what we had in the previous chapters of COVID in Israel. So Israel was one of the first countries to introduce a general lockdown as a mean to try and flatten the curve. Nevertheless, the proportion of COVID-19 deaths within the long-term care facilities and shelter home residents in some weeks had reached over 65%. It is also worth to note that the percentage of inpatient long-term care older people in Israel is relatively low. Therefore, the share of mortality within the long-term care facilities is relatively higher than what was expected. Next slide, please. After a cry for help by the long-term care facility management and the family members, the Prime Minister appointed a national level force team called the Fathers and Mothers Shield. The main point was having a centralized management of the pandemic within the long-term care facilities. So this was mid-April 2020, relatively very quick. Next slide, please. We identified 3 main policy measures that basically made the tripod to manage this high-risk morbidity and mortality in the long-term care facilities. The first was changing of testing policies and introducing screen testings also to residents and employees of the long-term care facilities. The second was managing the visitation policies and defining one supervisor who is in charge in each facility. And the third, setting up coronavirus wards within the geriatric institutions. We published a paper within the Journal of Long-Term Care, and I will be happy to share the DOI afterwards in the chat. Next slide, please. So, except for the first wave, Israel has experienced the COVID-19 waves earlier than many other countries. The fourth wave in Israel started mid-June. The new government issued new restrictions only at the beginning of August within the booster campaign, coming in together, okay? At the beginning of April 2021, Delta was seen for the first time in Israel. By May 31st, the share of the variant was 73%. If you will look at the graph, you will see that there were hardly any positive tests at that period, okay? We're talking about the end of the third wave before the beginning of the fourth wave. So how do we have this information? One of the reasons the task force gave the Ministry of Health to explain why some screen testing must continue in the long-term care facilities, even though the morbidity is extremely low, is that it will enable to detect outbreaks in the long-term care facilities at an early stage, as well as to be able to detect outbreaks and variants in the community surrounding those facilities. So some of the early detection came from the long-term care sector as some screen testing still continued. This is an important point because we're usually looking at what we can do to protect the long-term care people, okay, residents and the workers, but this was a very good indication of what is happening around and can we spot it before it's widely spread. The answer was yes. Next slide, please. Israel was the first in the world to give the booster shots. We also were hit hardly with the fourth wave, and we also gathered a lot of data and analyzed it, and several really important papers in the New England and JAMA, et cetera, were published regarding, I'm talking about the general management of the pandemic in terms of vaccination. So this enabled the government to decide to give the booster even before the FDA approved it. First sectors were health workers, long-term care sector, and people aged 60 plus. So this is August 1st. The booster campaign has started. The fourth wave started beginning of June, and here we are 2 months after with the booster shots. Next slide, please. Although the booster shot was approved in the first, although the booster shot was approved the first in the world, the task force managing the pandemic in the long-term care facility, on the other hand, has faded out after the third wave. With such morbidity in the community and only a matter of time that this will hit the long-term care facilities as well, even if we are giving shots very early at time. So what happened is that for reasons that we'll discuss in a minute, the task force really faded out. They only left a small staff to manage mainly some sort of screen testing and transferring of patients from hospitals to corona wards or to the facilities back, and that was about it. Next slide, please. So August 11, We're having already outbreaks in different long-term care facilities already, and we have new directives from the Ministry of Health discussing the way that monitoring of residents should be in terms of taking temperature again and other different measures to see if there's any outbreaks. Different directives for the referral to general hospitals and transfer to corona wards, and booster vaccination started August 1st, and there was a discussion regarding if there are needed informed consents again from the residents, and visitation. That was a really interesting point. Remained the same directive from June 2021, as if nothing's happening and there are no outbreaks at different long-term care facilities. Not only that, what happened is that on August 3rd, the restrictions to the general population were out again. And on the other hand, there were not updated restrictions for visitation in long-term facilities. That took 3 weeks only after. So we had a situation that you can't go into a restaurant if you're not vaccinated, but on the other hand, you can go into a care home. Also, PCR tests for transferring to and from long-term care facilities. And the one thing that did happen was that they made sure that every facility had an outbreak kit with PPE, with equipment, with whatever is needed in order to manage an outbreak once it occurs. Next slide, please. So the task force was sort of assembled back at the beginning of the fourth wave, but it didn't go back to be the size and have the resources as before. Whether the reason is political because of change of government or personal people in the Ministry of Health, or a little bit of power games, I will let myself say, or the wish to just save money, I have one question. And the question is, how did we forget what we learned so quickly? Thank you very much.
That is a scary question, Sharona. And yeah, let's see. Thank you very much for sharing. We're going to go to Mexico next. To Mariana, you're ready?
Yeah. Can you hear me okay?
Yeah, we can. Thank you.
So I want to just Sharona, thank you, Adelina, for not only inviting Mexico and myself to present, but also for organizing this wonderful event. This is a huge effort, and so big congratulations. And I always feel a bit wary of presenting with all those countries, because you'll see how our experience is very different. So next slide, please. So just first to speak a bit, I know this is long-term care and COVID pandemic, but a bit of the numbers in terms of total COVID-19 confirmed cases. Up to date, sorry, there have been 3.9 million confirmed cases. In general population, of course, not long-term care. But however, there's no strict like epidemiologic seeking or testing at the population level. So likely this is a bit underestimated, even with the high numbers. Only of all these cases, only 15.1 have been treated in hospital, which of course could mean not very acute cases, but also we know that for many this would be probably too late into going to seek hospital care or no beds available. So we don't really know if that 15.1% is all those that could have had a some treatment. And also total deaths at the moment are 308,000, but also most likely underestimated, as not always the testing and the confirmation was made. So the big problem is, in terms of long-term care settings, is that we don't have a compulsory national registry or a unique institution that regulates and evaluates long-term care institutions, including establishing compulsory care standards. So this translates into an absence of a clear surveillance system and causes a vacuum regarding their conditions during the COVID-19 pandemic. As a consequence, official information about rates of infection, a total number of cases, residents and staff, or mortality due to COVID-19 in long-term care facilities is not readily available. From data of a partial census of long-term care residential settings for adults, including care homes, it is estimated that less than 1% of older adults live in long-term care settings. So while this is a very small proportion compared to, the total number of older adults living in the community, which is 12% of the total population, most long-term settings were already facing non-optimal conditions, such as lack of well-trained human resources, income and financing problems, or, as I was saying, no care guidelines to follow. So we can imagine that, as we were, in the previous, some of the previous presentations, even if it's a small populations, sort of one case has a lot of weight, right? So also there were no clear guidances for long-term cares, with the exception of, recommendations for keeping older adults safe in general population, and some vulnerable population groups. No other guidance was generated. So the National Institute of Geriatrics took as a task, we are an institution decentralized from the Ministry of Health, had them sort of took themselves the task to generate some infographics and short guidelines using recommendations from international sources, including WHO and other countries. I remember very early last year, we had a conversation with people from the government in Israel, because, trying to sort of see what we could do, or what recommendations we could generate. And this has been constantly published in our, also in our webpage and social media, but there was only so much that we could do in terms of reaching all of these institutions, especially outside Mexico City and the metropolitan area. So currently we are undertaking a research project together with the National Institute of Geriatrics and the Family Development System to follow up with institutions that are captured in this partial census that I was talking about, to see about, general data on infections and deaths. And it reminded me a bit, much less sophisticated, but, about what Portugal is doing, trying to, with a research project, contact institutions and see what's happening. And hopefully being able to give them specific recommendations or support as they are doing. And so that was a great, I could maybe contact Oscar later. So next slide, please. So some lessons learned for long-term care settings. Of course, the absence of a formal publicly funded long-term care system and of national compulsory register or qualification system for all care homes not only generates the absence of timely information and procedures, but it also prevents obtaining adequate information on the characteristics, cases, and measures, what they did. We really don't know. We had this information out, but it's very hard to know individually what happened. Of course, long-term care settings need care guidelines on how to better support and take care of the residents in general, as they were saying in Norway, and particularly in times of crisis. And also, of course, not only a pandemic. Think that we have earthquakes, and some other states have hurricanes. So there's a lot of crisis situations that we really need to support long-term care settings to be prepared for. Also adequate information systems that require care homes to gather and report specific information are urgently needed, because right now there's a guideline, but they really don't, there's no, nothing happens if they don't report it. I mean, probably some of them don't even know who to report this. In general, of course, they need to recognize and implement support strategies for particularly vulnerable groups in crisis situations. Also, for example, unpaid family carers, persons living with dementia, persons living with disabilities, that, it's not only long-term care settings. And obviously the evident pressure on the healthcare system in times of crisis highlights the urgent need for universal healthcare system that it's adequately funded and equipped, both in terms of infrastructure and human resources. And also inequalities in access to timely care, because there was a big problem in terms of sort of who could access hospital beds or respirators and things like that. And of course, that happened in many countries, not just in countries like Mexico with not very well developed systems, but this is also something that has to be taking into account. So next slide, and I think that's the last one. So how should things move forward? In the short term, of course, the extension of health information systems. So they include long-term care institutions and increased population level self-report of cases. Because as we were saying, most cases were treated at home within the private sector, so mostly were not reported. And because long-term settings like care homes are mostly private institutions, even if they are not for profit. I mean, when they access services or call a doctor, also it mostly remains within the private, what we would call the private sector. So of course, it's very hard to know about the real number of cases in general population and care homes. Of course, we need to generate a national registry of all public, private, and non-profit institutions that cater to older adults and people with disabilities. And this will allow the implementation of the norms and standards of care and evaluation at the national level. Of course, we need to generate those norms and standards first. And also the generation of compulsory norms for care quality and safe standards and an evaluation system. And in a longer term, of course, monitoring and evaluating in line with these standards of care. But also for example, lockdown has exacerbated the already difficult conditions of unpaid family carers and also care staff at nursing homes because, for example, because there were no guidelines, each one had to sort of figure out what they were going to do in terms of visiting, restrictions, not. So that's very important. And of course, support strategies for people also that is care at home and sort of could be receiving care at a nursing home. And I think that's the last one. Yeah, so thank you very much.
Thank you very much. And now we'll go to Germany, and Thomas, I think that was very quick. Thank you.
Right, if I find my microphone, I can actually start. Adelina, thank you very much for inviting me. I'm being mindful of time. I'm trying to keep it short so that there might be some time for some discussion. So, and I don't think I can give a complete overview of everything that has happened here. Just a quick snapshot and a few thoughts about what's going on. So we've seen over the course of the pandemic over 7,000 outbreaks in care homes. So that's at least 2 persons infected. And we've lost 25,000 lives in nursing homes and care homes in Germany. That is out of a population of 80 million as a whole. And let me just briefly check, 4 million people who receive benefits under the long-term care insurance system. We don't really know how many people were affected who are being cared for in their own homes because there's basically no data on that. The measures were pretty similar to that seen across the world, I suppose. So for infection prevention and control, long-term care facilities were closed to visitors. And these closures also impacted the delivery of healthcare services from outside providers. And that's quite an important aspect, because in our long-term care facilities, we don't have physicians on site. We don't have physiotherapists on site. And locking institutions to service providers and service providers staying away because they're worried probably had quite some impact on the residents, negative impact, exacerbating the consequences of the pandemic. We've seen social isolation, lack of exercise, everything you all will be aware of as undesired effects of the IPC measures. There has been some documentation around the increased stress, both for family carers and healthcare workers, and we've received lots of reports from ombudsmen and other institutions in the system, especially from very, very distressed carers. Also a situation where carers stopped services completely. They didn't have nurses coming in or paid carers come into their homes, increasing the stress on them. Services were closed, and we believe that put especially informal carers under a lot of stress and will have led to very difficult situations for many, as well as for a healthcare workforce. And you will all be faced with the same situation, that basically everyone is absolutely exhausted who is working in the health and social care system after the course of this pandemic. And many staff have quitted their jobs or are intending to quit as soon as they feel that there's an opportunity. We now have residents in residential care facilities mostly vaccinated twice, and the booster shots are on their way. But vaccination levels of staff remain questionable. So we don't have exact numbers. Only one state has good numbers on that. The other federal states don't. And we probably have care homes where we still have 50% of unvaccinated staff, and there's probably lots and lots where we've reached 100%. But we're not quite sure. So lack of data there as well. But we, across the board, we have mandatory testing regimes in place, and that applies to staff, residents, and visitors. So just 3 key lessons. I mean, there's lots more, but for me, there's really 3 key lessons so far. The first one is we need to look into crisis preparedness. And I'm deliberately not choosing the word pandemic preparedness. I really think we need to look into crisis preparedness, have procedures in place for times of crisis, and have equipment, not only, but also personal protective equipment in place, but really look how we structure services under times of severe emergencies. What are core services we need to maintain? So just an example, in this country, we left childcare services, kindergarten, open to provide essential services. We didn't do the same thing for the care system necessarily, especially for the community care system. And you wonder why. That doesn't really make sense. We need to have procedures in place that allow to safeguard the well-being of staff and residents alike. And collaboration is a major issue in our system as it is. Collaboration is not very well established in a for-profit healthcare, for-profit social and long-term care system. And collaboration was really important when now during the pandemic, and we need to think how different providers work together in a structured way. For me, very important, we've learned, and I think this is part of the evidence around the world, that residents in nursing homes cannot effectively be shielded against high community prevalence and incidence. It is just, all the evidence out there says it is linked, and we need to bear that in mind. So I did like what Sharona said about the care homes as early indicators. So there's a two-way relationship there, really, we need to think of, I think. We find that community care is often forgotten. Stakeholders from community care, carers, people who receive care, feel that they're almost treated as an afterthought of the system. But most people who need care live in their own homes, and we need to take care of them as well, with specific guidance, specific ways of protecting them, and especially the ways we organized the vaccination, which was also basically happening as an afterthought for those living in their own homes, way after those in nursing homes received their tasks. There's lots of reforms always ongoing in our systems. It's almost a bit of change and choice, a change fatigue situation. But working conditions in long-term care certainly have come under renewed scrutiny, and pay increases are being debated again. Unsure where that's going to lead. The law has been changed, and crisis preparedness is now part of the regulatory requirement and is part of the checks that all long-term care facilities have to undergo. How that is going to work out and how that's going to look like, we don't know yet. It's just been put into the law. There is a discussion about vaccine mandates for everyone working in certain settings, including care homes. That is highly controversial, as I'm sure you're all aware of. And the incoming government, we just had federal elections, and the government is in the process of assuming office. They propose a greater integration of healthcare and social care on the local level, on the municipal level, because this is the weakest link in our system. And I'll finish with that municipalities and local governments have basically no authority over what's going on in the health and social care system. And I'll leave you with that.
Thank you very much. That was quite something. You packed a lot in, all of you, and I am very grateful. We obviously cannot go into things in a lot of detail, but we do have 5 more minutes. And I would like to invite any reflections and comments across countries, anybody who's been listening as well. And I do think there is a bit of a theme in this, getting things right as when things are normal is what we'll set as well for the future. And I wanted to highlight, I think Kai, like Singering, I think he's somewhere still here, also shared a link on preparedness for older, so it's a policy brief on older persons in emergency situations. And I think quite a few of you have also highlighted the preparedness for any other events that are coming, especially in the context of climate change and so on. So any other thoughts, comments, want to bring up? Any questions for any of you across the world? And
Adelina, I would just like to say this, it's been really, really interesting and be able to look at these from different country perspectives. This idea of preparedness, I think, certainly came up in some work we were doing, interviewing staff and family, and particularly around family visitation programs and the issue in long-term care of locking out families who provide so much not only emotional support, but also hands-on support, and the need to see what has happened and use that information as a blueprint for future outbreaks or future emergency situations where there is some concern about visitors coming in, but there are now processes in place that we shouldn't have to have people be deconditioned because of a pandemic. So just wanted to say that.
Thank you. Any last quick comment? I have one actually. Thomas, yes.
Just to add to what Janice said, I think totally agree. And the next crisis, the next pandemic will look nothing like this one. And so sharing all of our experiences, which are so different across the countries and the same again, will help us to broaden our minds to be better prepared, whatever may come.
I'm going to throw in an anecdote, which is that, and that kind of links to the next session as well, which is that in England, as you know, we have a wonderful situation because we linked COVID and Brexit at the same time. And we do have a lot of issues. And one of them was that we were running out of petrol because we didn't have enough drivers. And what happened was that we were having a shortage of petrol. And guess who weren't able to get petrol and get to work, which was the people working in care homes and home carers. And they were not, and even after everything that's happened, this country wasn't able to have a measure to ensure that these people who have these really crucial jobs, and I was thinking of what you were saying, Thomas, about making the way that there was provision for childcare, there wasn't for people with care responsibilities. There was no planning in this new type of emergency, completely different for home carers, people working in care homes, to have priority access to petrol, particularly home carers who drive from one house to another. So just, you know, an already happened example of something that hasn't been learned in town. This is a kind of segue into the next session. Thank you very much, all the panelists. Not a lot of time for discussion today, but I think we will keep talking to each other for the next few years. I do think we will be reconvening and sharing. We'll also be able to use this living report, and I will be sharing some of the links for the countries that we have heard about today, at least the ones that are more complete as well. So thank you all.